Great. So good afternoon, and thanks for the invitation to this meeting. So I'm Tawfiq Choudhury. I work at Lancashire Cardiac Centre in Blackpool in the UK. Just to give you a brief summary of the case, this is an 82-year-old gentleman who has multiple comorbidities, including peripheral vascular disease, chronic kidney disease stage 4. So his baseline creatinine is around 260, and he's known to have type 2 diabetes as well. So he came in with an STEMI and recurrent chest pain while he was an inpatient on the ward. We did a coronary angiogram with minimal contrast showing severe distal left main lesion, severe disease in the mid-LAD and in the mid-circumflex as well. And so we wanted to take him to the heart team meeting, which he was discussed at, and they said he was not a candidate for CABG and maybe to go for medical management or if possible then high-risk PCI. So by this time he was having further episodes of chest pain. His creatinine had worsened. His EGFR was now 14. So we've built up an experience of doing low contrast PCI in high-risk patients at our center. And after discussion, we decided to take him on for ultra low contrast DK crush of the left main stem as well as PCI to the mid-LAD and circumflex artery. So multivessel as well as DK crush of the left main. And this case essentially takes us through the entire procedure, including the mid-vessel PCI and the DK crush of the left main with using zero contrast. So absolutely no contrast using IVUS co-registration technology, and also goes through some of the challenges that one might face when doing such a case in such a complex anatomy, in such a complex patient. The thing was that this was a case where the patient, as soon as he got on the table, was having further chest pain with very dynamic ECG changes. And so we had to put in an upfront balloon pump as well, which helps stabilize the patient and the ECG. This is essentially the case. We used zero contrast for the whole case, and then we did a final angiogram with 4 mils of contrast to show the final result. Of course, we checked the final result with IVUS, a full IVUS study.
So Tawfiq, was that angiogram? That angiogram was undertaken biplane. You showed 2 different projections.
Absolutely, yes. So we've got biplane labs in 2 of our labs, so that's what we used. Yeah.
Yeah, I mean, it was a fantastic result and a beautiful case. So I'm not familiar with the Philips system, but clearly having co-registration using the wire as your marker for the vessel outline, is there anything you have to do differently for the co-registration setup than you would do ordinarily by using the angiogram, using the contrast to delineate the vessel?
Yeah, so it's absolutely key to have a full study of the original angiogram. So to look at the lesion outline, the vessel outline, study the lesions where they are, and to select the appropriate views that one is going to use, and then to print out those angles and stick them on the screen. That's what we do in our practice, so that we have exactly those same angles that we're going to use when we position the camera, because that's the same angle we'll be doing the IVUS co-registration on. I mean, otherwise, the important tips is that when the guide is in view, to make sure that there's enough of the guide in view so that the 3 dots of the Eagle Eye IVUS catheter are in view. The other important things are to sort of make a good note of the calcium, because that will help us wire the vessel. But once the vessel is wired, then one can take a dry acquisition of the wire, and that can be used as a roadmap instead of doing a contrast angiogram.
Yeah. And then clearly, I mean, this has been published previously by Ziad Ali and the group in European Heart. And so in that first report, they were using FFR, or in that circumstance, FFR, but with your Philips system, IFR, and also then echocardiography to ensure that you haven't got distal vessel perforation and things of that sort. Are those measures that you've also adopted, or obviously not in this case, but are there other measures that you have to undertake in order to confirm safety?
So to confirm safety, we've got certain rules that we follow from our side, which we've made. I think the key thing to remember in such a case is that using no contrast isn't an absolute must. Patient safety comes first. So the times when we will use contrast is for situations where there's hemodynamic instability, when there's an arrhythmia that's causing hemodynamic compromise, or the patient is having recurrent symptoms. With regards to your question about routine echocardiography post-procedure, I think if the patient remains completely stable and hemodynamically stable, patient's asymptomatic at the end of the procedure, we don't do mandatory echo right at the end of the procedure. Of course, when the patient gets back on the ward at some point, they will have an echocardiogram, but we don't do one straight away because in our experience, in the series of cases that we've done, if the patient's stable and the hemodynamics are fine, then they're usually okay on the subsequent echoes as well.
Okay. My comments is very interesting. I think that you should use all the landmark that you can. The guide wire and the side branches, the calcium, everything was done perfectly. For the bifurcation site, is the left main. So the pitfalls that you can have, to have a longitudinal deformation. So you should identify exactly, if you go to the ostium or the left main, where is the ostium? And so you use the wire, I think, I remember, the wire.
The floating wire technique, yes.
Wire. And this one, but sometimes it's not so precise, but you have to arrange, and based on the coronary angiography made on baseline, also the projection that you used, the co-registration was perfect. And then using the decay crush, as you did, it's quite, you have some margin of error because you can protrude a little more. It's preferable to protrude a little more than to miss the ostium. You protrude 1 millimeter, I think it was perfect. But even if you use other techniques for provisional, during the pot you can, using some, enhancement, if you have the enhancement of the stent, and to identify, do your pot, and then you go with your T or other technique for bifurcation. I think it should be used more frequently when you have these patients that are not candidates for other and are high risk for renal failure. Good case. I like it.
Thank you. And yes, in answer to your question, we do have stent boosts, so we use that a bit, and that really helps, especially with the wiring of the side branch as well. That helped us show where we were crossing with the wire.
With provisional, sometimes the problem with provisional is that it's difficult to check angiographical because you are used to angiography, but you have the IBUS, so you should use the IBUS to see if in the side branch ostium everything is okay. You have no dissection, so it's a new concept that is difficult to enter in our mind, but we should use more imaging, and then also adapt ourselves to this type of intervention without any contrast.
Thank you. Yes, absolutely.
So we're hearing a lot in the meeting about the role of OCT for assessment of wire cross, and I wonder, did you use the IVUS to achieve that? So taking it to a level of understanding exactly where you're recrossing through jailed side branch and such like for the optimization, or are you just using it simply to ensure post-dilatation and expansion of the stents was adequate?
More the latter. We didn't use it for the precise recrossing, but we used it more for the final result and making sure that the stents were optimized.
Yeah. Well, you got a fantastic result. So thank you for sharing it.
Thank you very much.
Really good.
Thanks. Great, thanks. Thank you for inviting me to present. By the way.
Thank you.